Hi, we are going to talk about disorders of gastrointestinal function. This is part one. So part one will cover pretty much the mouth to mouth, esophagus, and stomach GI, or well, okay, so the whole thing is kind of GI, but the intestines, large and small intestine. And then we'll come back in part two and we'll talk about the liver, pancreas, gallbladder. Okay, so where a couple of things I'll point out here on this slide. And first of all, I'm assuming we already know the path of food through the esophagus, through the stomach. It's just a big tube. That's really all we've got here is a big tube with a big expansion here that's the stomach, kind of a little holding area. But really it's just passing through this long tube, and different things are happening in different places, but the idea is to kind of give food this chance to be sort of enzymatically broken down. Enzymes are added, absorption takes place, that kind of thing. Now, if we look at the makeup really of anything along the GI tract, you can see that there are a few different layers here. You've got the mucosal layer that is on the inside, and then you have the muscular layer and the serosa, which is connective tissue around it, that's on the outside. So that's going to kind of become important when we talk about things like diverticula, which kind of pushes out that muscular layer and causes some bulging, and then stuff gets caught in there. We'll talk about some enteritis. So maybe some bacteria might get in there, or maybe there's inflammation for reasons we don't even understand. But this inner mucosal layer can become inflamed, and that can cause a lot of problems. So if you kind of, as you go through and we start talking about the inflammation that's occurring in here, you kind of might want to think back to sort of looking at having this image in your mind of what's going on. It's that I don't know, that might help. It always helps to have a have a picture of exactly what you're dealing with. Kind of makes it more real. So let's talk about some terms. Anorexia. A lot of us have heard about anorexia for many years, but we hear about anorexia nervosa, which is a disorder where people don't eat for whatever reason. Anorexia as a symptom is a lack of a desire to eat. So sometimes people, medications can do this, illness can do this, it just makes people not want to eat. So that would be listed, the symptom there would be listed as anorexia. So lack of a desire to eat despite physiologic stimuli that would normally produce hunger. Vomiting, I think we all know what vomiting is. We'll talk about it a little bit more, but that's the forceful emptying of the stomach and intestinal contents through the mouth. So that's what vomiting is. So lots of things can stimulate it, and common symptoms: hypersalivation, tachycardia. Nausea is that feeling where you feel like you're going to vomit, but it's a subjective experience, so everybody experiences it in their own way, that is associated with a number of conditions. So usually nausea, vomiting, diarrhea kind of all go together. Retching is non-productive vomiting, and projectile vomiting is spontaneous, that isn't really associated with nausea or retching. It's just vomiting that occurs without those things. Okay, diarrhea. Excessive frequent passage of stool. So this is how we're going to define diarrhea. It's got that rhea, or that RREH or RRH, which usually is a flow of something. In this case, it's your stools or feces. So it's broken down a couple of different ways, and different places, different books and stuff will kind of break this down a little bit differently. But here we can talk about acute, which of course acute is sudden onset and usually doesn't last very long. Chronic is when it won't stop, it continues. But under acute diarrhea, there's large volume, small volume. So large volume, and when we think about volume, we're talking about an increase in water content. So we're throwing off water. And a lot of times this tends to be associated with something going on in the small intestine, just because that's where water is mostly absorbed and can be secreted. Is most of the water handling is done in the small intestine. It doesn't tend to be bloody. Large volume doesn't tend to be bloody, or at least not noticeably so. And it's associated with abdominal pain, cramps, bloating. Small volume is a lot of times caused by increased intestinal mobility. So if you want to think about that, then that kind of makes sense, because if you're pushing stuff through a lot of times, then you're going to have numerous small volume defecation events, pooping, diarrhea. So increased intestinal mobility, but it's going to be smaller volume. So usually affects the colon, so volume is not significantly increased. So that's the other thing. So we mentioned up here with large volume, you've got more water to deal with. And the colon, really a lot of what takes place in the colon is some more reabsorption of water. Most of that reabsorption and water handling in general is done by the small intestine. But there's a little more water reabsorption that takes place in the small intestine, or the large intestine. But it usually affects the colon, so the volume is not significantly increased. It may be associated because of some of the organisms that are associated with it, may be associated with fever, bloody diarrhea, especially if we're talking about something that happens in the colon. Less abdominal pain, and it tends to happen more in the lower quadrants. So chronic is something like irritable bowel syndrome, or inflammatory bowel disease, colitis, and various colitis disorders, Crohn's disease, things like that. Something that kind of keeps going on, and we'll talk about all of those. So characterized by frequency, urgency, and colicky abdominal pain, colic, or chronic. Constipation is defined as infrequent or difficult defecation, so the opposite, more or less, of diarrhea. So there's normal transit, which means difficulty in defecation, but responds to fluid and fiber intake. So fiber really, it's not something, when we talk about fiber, it's not really something that's absorbed. It's not a nutrient in the sense that we absorb it and take it in and our body can do something with it. It's not absorbed. That's the whole point. It adds bulk to the feces, and that kind of gives your large intestine an easier time, or small intestine too, I suppose, an easier time pushing it through. Okay, so that's what fiber does. And so there may be difficulty with defecation just because it's a little more compact, and so it's harder for the colon to push it through, colon being the large intestine, maybe harder to push it through. And so that may be the cause of it. So things are in general working the way they're supposed to be, but there's not enough fluid, not enough fiber to manage it. Slow transit could be caused by, well, it could be caused by a lack in muscle activation. So the peristalsis doesn't happen the way that it's supposed to, and that's going to be infrequent. Okay, so that's going to be so infrequent bowel movements. Things are going to kind of get backed up, and it makes sense there also that it could be neurogenic because of this effect on peristalsis, on motility. So moving things through. A lot of times constipation is associated with decreased water in stool. If it kind of runs through more slowly, especially, then there's a lot of reabsorption, or a lot of absorption that can take place of water. So it's a lot of times, associated with that. So problems that may lead to constipation: neurogenic disorders, Parkinson's, hypothyroid, medications is a big one, low residue diet, that means low fiber, sedentary lifestyle, excessive use of antacids, changes in bowel habits, so maybe holding it, putting off defecation for too long. So we're moving on to I guess we're moving on from these terms that we were discussing and talking about esophageal motility, but we have really a couple of more terms that are associated with that. So these are swallowing disorders, okay, because that's what the esophagus is. It's moving food from the throat or from the mouth down into the stomach. So dysphagia is difficult or painful swallowing. Dysphagia with a G, dysphagia. May result from narrowing of the esophagus. That makes sense. If the esophagus can't widen to allow food to move through, it's going to be more difficult and probably painful. Lack of salivary secretion, so saliva can act as a lubricant to kind of help move things through. Weakness of the muscular structure, so you've got peristalsis again, moving the food through the esophagus. So that's smooth muscle contraction, that peristaltic movement, that wave-like movement. And if those muscles are weakened, you're going to have a hard time pushing things through, and you may have to swallow several times to get it to move. And this, of course, disruption of neural networks, and of course that's going to affect the musculature of the esophagus as well. So manifestation: stabbing pain at the level of obstruction. Considering they're, well, I mean, these are going to be associated with an obstruction because you're trying to swallow food, and that's going to be there. So wherever that gets caught up, I guess. So discomfort after swallowing, regurgitation of undigested food. So regurgitation means that it's going to move back up. If you can't get it to go down, it may move back up. And then another problem sort of associated with the regurgitation is aspiration. It may move back up into the throat and then decide that it's going to give the trachea a try and move down into the lungs, which is what aspiration is. Not that that's a good solution, but that can happen a lot of times. So unpleasant taste sensation may occur probably for reasons that the food is kind of making its way back up, I assume. Vomiting could happen, pushing it back the other way. Weight loss just from not getting as much as the nutrients that you need. There's also something called achalasia, which is failure to relax. Okay, so you have this little thing, this lower esophageal sphincter. So you have this sphincter that sits at the bottom of the esophagus. It's supposed to open, which means relax, and then close. Okay, so it's supposed to open when food comes down, part of that peristalsis, to send a signal to tell the lower esophageal sphincter to relax. Well, if that doesn't happen, then food can get backed up. Okay, so the lower esophageal doesn't effectively allow that food to pass through. And that could be neurogenic as well, related to inhibitory neurons in the myenteric plexus, which is the network of nerves sort of providing that region or innervating that region, with smooth muscle atrophy. So now you've got weakened smooth muscle in the middle and lower portions of the esophagus. Okay, so maybe you're not pushing hard enough, maybe so some kind of a muscular problem with pushing the food through. And so that's not allowing the food to go in. So may cause esophageal dilation above the lower esophageal sphincter, which is kind of what we see here, and aspiration danger when lying down. Again, that's when it moves back up into the throat and may move down the trachea with an inhalation. Now, gastroesophageal reflux is also, again, where that lower esophageal sphincter is sort of relaxed and open. Okay, so this is supposed to, when you swallow, food is supposed to move into the stomach, and then that esophageal sphincter is supposed to close back up. So the acid that's in your stomach as part of the digestion and to kill bacteria and things like that, that acid, that lower esophageal sphincter is supposed to prevent it from moving back up. Now, if that doesn't happen, then it hurts. It's painful. That's pyrosis. That's heartburn. So we can kind of feel that has nothing to do with the heart, but it's kind of in your chest, throat area. If it's persistent, so this has probably happened to everybody. But if it's persistent, then we give it the classification of GERD, so gastroesophageal reflux disease, and that's when it continues over and over to reflux the gastric contents into the esophagus. So this could be caused by an incompetent esophageal sphincter. Remember, when we have incompetent valves, that means they're not really closing right and they're maybe letting things back through, regurgitation. And or conditions that increase abdominal pressure, such as delayed gastric emptying. So if the stomach and intestines are kind of getting backed up, then it can push back up through that esophagus as well. So gastric emptying, gastric always refers to the stomach. So if the stomach doesn't empty, then it gets too full, increased pressure could push back up. So common in children due to a small capacity of the stomach. Manifestations: heartburn. Heartburn is the main one. So regurgitation of chyme. Okay, so you're moving what used to be food, but now it's mixed with stomach acid back up through the esophagus. Upper abdominal pain within 1 hour of feeding. In children, feeding issues, and children, in this case, I think of very small children, feeding issues, esophageal bleeding could happen because it's damage that can take place. Irritable pain with swallowing and respiratory problems. So it's treated with antacids. Antacids, which like Tums, things like that, the calcium or magnesium bicarbonates. And H2 receptor antagonists. So H2 refers to histamine, histamine 2. There's histamine 1, histamine 2 receptors, different receptors, and the histamine 2 receptors are the ones that are located on like parietal cells that are responsible for producing acid. So you activate those histamine receptors on the parietal cells, and it tells those parietal cells to make more acid. So if you antagonize those, then that kind of shuts it down. Or you can stop the proton pump, proton meaning hydrogen, which is acid production. So this normal activity we have of sort of pumping hydrogen into our stomach to make it acidic, we can just shut down that pump. Okay, so proton pump inhibitors. Those are some other treatments. Complications. Well, we're talking about acid getting up into the esophagus, especially the lower part of the esophagus. So the esophageal mucosal, so that's that inner layer, damage can take place from that acid. A stricture may develop, and that's kind of it's really scar tissue, so something that's not very elastic that can develop and with repeated damage, and it won't allow the esophagus to stretch in that area. Okay, so it creates something we would call a stricture. So that would result in a narrowing of the esophagus, may result from repeated damage and the formation of scar tissue. And another big one that you need to know is Barrett esophagus. So Barrett esophagus is when it's pretty specific because, and the specificity is, yeah, you're causing damage to this area above the lower esophageal sphincter in the esophagus, but it's something known as metaplasia, and we've talked about metaplasia. Metaplasia is changing from one cell type to another. So this might be a squamous epithelial cell, and this may be a columnar epithelial cell, a ciliated columnar epithelial cell. Now, if you remember, in the lungs, smoking, irritants like that can cause these ciliated columnar cells to turn into squamous, and you lose your cilia. In Barrett esophagus, it's just the opposite. The squamous will turn into the columnar. Okay, and that's kind of the hallmark of Barrett esophagus. And the thing about that is, with a lot of metaplasias and dysplasias, especially when your cell types start changing, they can turn into these deranged cells. They can become dysplastic, and they can become cancerous. And that's the concern, is that this continuous damage is kind of messing with DNA expression, and maybe cell division is taking place, and you might have mutations that develop, and that could lead to cancer. So that's why we worry about Barrett esophagus. So the cancers, adenocarcinomas, adeno usually means that it's something secretory, so that would be in the lower third of the esophagus and stomach, and squamous cell carcinomas would be more in the middle of the esophagus, which are epithelial tissue. So risks include tobacco, alcohol, or anything else that can lead to that repeated damage to that area. There's also something called a hiatal hernia. So your diaphragm, which this is looking up. So this is like, imagine if you were, looking up from where the intestines are in the peritoneal cavity. So if you're looking up, you can see that the diaphragm covers this whole rib cage here, where the ribs are, kind of hooks onto the sides of these, and it kind of covers that whole area. And yet we have things that are moving through there. So you can see here the vena cava, so draining blood from the upper body. That has to get through the diaphragm, and your aorta is taking blood up to the brain and the upper parts of the body, so the ascending aorta has to move up through this diaphragm. And also, what we've been talking about, the esophagus has to move through the diaphragm. So we have a couple of conditions that can develop, and they're hiatal hernias. And a hernia is just a protrusion of something into an area where it normally wouldn't be. And in this case, you can see the stomach is protruding through this esophageal hiatus. So that's what we call that little hole, the esophageal hiatus. So the stomach is pushing through that esophageal hiatus, and so it's now kind of bulging up on top. And so that's a sliding hiatal hernia. It's common, usually insignificant, asymptomatic. You may not even know that you've ever had it. You may have had it and not even recognize it. However, there is something called a paraesophageal hiatal hernia, and that's when it sort of forms a pouch. Okay, so the stomach is forming a pouch, and you may have to actually have that removed. So the sliding hiatal hernia can resolve on its own, but the paraesophageal hiatal hernia may form this pouch, and then you may have to actually have it treated surgically. So part of the stomach enters the thorax. Okay, so this area up here, this thoracic area, from the perineal area, through a widened opening, often progresses, and if large, may require surgical treatment. Now, the real problem with this, or I mean, the fact that it's there is kind of a problem, but contents can get trapped. Things can get trapped in there and just kind of ferment. And I think of, you know, bacterial growth or something like that. And that can kind of lead to a bad situation. So contents may become trapped. The paraesophageal hiatal hernia is more common in people over 50, and it's often caused by weakened diaphragm muscles, because it's moving through this diaphragm. If that diaphragm is a little bit more, you know, squishy, like it's a little bit weaker, then that's more likely to take place. That kind of, I can kind of see how that would happen. So disorders of motility now. So one of the things we've kind of alluded to are these peristaltic movements, and the fact that there's this muscularis layer all the way through the GI tract, including in the muscle. And so there are lots of things that can interfere with the peristaltic movement. That's motility, is the moving through of things. We also have valves. We have this lower esophageal sphincter we've been talking about that can get blocked, and we also have something called the pyloric sphincter. So the pyloric sphincter, while the LES, the lower esophageal sphincter, is letting food into the stomach, the pyloric sphincter kind of lets food out. It lets it out in spurts. So it'll let a little bit out, and then when that duodenum gets stretched, it closes it, and then when the stretching goes the way of the duodenum, it opens again, and it keeps opening and letting food out in spurts. So any of these things can, either the motility itself can be disrupted. The sphincters all along the way may not open like they're supposed to, or it could just be some object has gotten in there and blocked it, or it could be twisting of the intestine. So if the intestines twist, that's another type of obstruction. So, or it's an interruption in motility. So that's motility in general. So we're going to kind of go through a bunch of these. So first we'll talk about this pyloric obstruction. So that's a narrowing, blocking or narrowing of the opening between the stomach and the duodenum. The duodenum being the first part of the small intestine. Okay, so that means that this area here is not food's not moving through the way it's supposed to. So it can be acquired, or it can be congenital. I don't always know what happened there, but for whatever reason, that pyloric sphincter isn't functioning the way that it's supposed to. So what happens? Manifestations: epigastric pain. Okay, so fullness, especially. I mean, your stomach is going to become swollen if food's not able to pass through the way that it's supposed to. Then your stomach can become swollen. Nausea. You might end up end up moving that stuff back up through. Succession splash, which is a sloshing sound during sudden movement. Yeah, we've all experienced that. It doesn't always mean that your pyloric sphincter is an opening though, but it is associated with this. Vomiting, yeah, get rid of it. Get rid of the food that's in there since it's not leaving. With prolonged obstruction, well, malnutrition. You need those nutrients. You ate for a reason. Dehydration, same thing. Water, a lot of water absorption happens in the intestines. If you're not moving enough water through, then that can be a problem. And just the pain in general, overall, everything kind of together can cause extreme debilitation. So now let's say that we have food that has moved through the stomach and into the intestine. So now we're going to talk about some intestinal obstruction that may, in the large intestine is what we a lot of times hear is the large intestine, is the colon. And so any kind of intestinal obstruction, be it the small intestine or the colon, is what we're talking about. So maybe chronic or acute. Mechanical makes sense. Something physically inhibits movement. Okay, so you have some kind of a blockage. Something has stopped movement through the intestine. You may still have some motility. So your intestines are still trying to push the food through. Maybe severe colicky pain, probably around the site of the obstruction. Borborygmus, which is a rumbling or a gurgling noise. You're going to hear noises, and I think that's the important thing to notice with mechanical is that this interruption may cause an increase in noise as gases get trapped in there, and it's trying to push it through, and it's putting pressure on it. So you're going to hear a lot of noises associated with this if it's mechanical. Okay, and I'm drawing the difference now between that and paralytic. If it's paralytic, that means those movements aren't happening. So for mechanical, something blocking it, audible high-pitched peristalsis, peristaltic rushes, awareness of intestinal movements, so the patient's going to know that something's going on in there. They're going to notice a little bit more activity, but they're also going to notice pain, and then and I don't know if they'll notice, but food is not moving through the way that it's supposed to. Paralytic is when movement stops, so you're not going to hear anything. So that's your silent abdomen. You put the stethoscope down there, you try to listen for abdominal noises, abdominal sounds, and you're not going to hear much or anything. So movement stops due to neurogenic or muscular weakness, muscular impairment, something like that. That's paralytic, and that's going to be continuous pain, as opposed to what we saw up here with mechanical, which was colicky pain, severe colicky pain. So continuous pain would be more associated with paralytic. Causes of obstruction. Well, there are lots of different things that can cause obstruction besides just, a marble or something like that, which usually doesn't cause an obstruction, honestly. So intussusception with invagination. So the way I think of this is your intestines are, they're good at trying to that peristaltic movement, they're good at just kind of moving stuff through. Just pushing food, squeezing it, moving it through. I think of intussusception as being one side kind of overtakes another. And so this intestine here, this one on the right, you can kind of think of it as starting to suck the other part of the intestine in. And so it starts to pull on the intestine itself and tries to move it through. And that's going to cause an obstruction. It's going to cause shortening of that bowel, because now it's kind of invaginated, which means taking it in through an opening, and so caused by movement of one segment of the bowel into the other. So that's intussusception, volvulus. Remember, the sigmoid colon is called sigmoid, S, because it's S-shaped, and so that can get twisted, and that's going to also cause an obstruction. Okay, and this little note here says, note the edematous section of the bowel. So that means you're sort of blocking off blood flow, nutrient flow to that area, and that can be, that can, you know, it can die. That tissue can die. And then a hernia. So a hernia is, we haven't really talked about this inguinal canal, but really you're supposed to have, this is more common in men because the testes descend. The testes are made up in the abdomen to begin with, and then they will descend during the first years of life, months, and move down into the scrotum. But that means they have to sort of break through the peritoneal lining in this area it forms something called the inguinal canal. And so what this picture is showing, now this isn't the only hernia that can happen. A herniation can happen anywhere where something is pushed through to another area, but what this picture is showing is a hernia that's taking place, an inguinal hernia, where the intestines are actually being pushed down into the scrotal area. And this, of course, can be palpated, so you can kind of push up through the scrotum and feel this sort of pushing down, especially when you have like a bearing down bowel movement kind of muscle contraction. It will push on that area, and you can feel it. So that's a hernia. The sac of the hernia is a continuation of the peritoneum of the abdomen. Okay, so hernial contents can be the intestine, the omentum, other abdominal contents that pass through the opening into whatever the hernial sac might be. So results, what does it do? Remember that borborygmus and the gurgling. Well, okay, so first of all, it can cause vomiting, and vomiting can lead to dehydration, electrolyte loss. Fluids will move into intestinal contents. So you have the accumulation of fluid that may take place, and you may have the accumulation of gas. Now that may come from either what has been eaten, or it may come from bacterial gas release, but gas can accumulate, fluids accumulating, and so now you've got that that gurgling sound that can take place, that sloshing. So compartment syndrome can happen, and that's when you have lack of blood flow to the musculature, which can cause a buildup of toxins in itself, and leads to that ischemia, necrosis, that kind of thing. Anaerobic bacteria that can get a foothold when you have stasis of flow of just about anything. Bacteria can start to grow and divide and kind of take over, and so they may produce toxins as well. So let's talk about stomach disorders, gastritis. And when you see gastritis, make a note of this. When you see gastritis, you're talking about the stomach. We're not talking about the intestines when we discuss gastritis. Now, so there's acute gastritis, chronic gastritis that we'll talk about, and then ulcerative disorders, which can also include the small intestine, at least the first part of the small intestine. So acute gastritis is pretty much what it sounds like it is. It's an inflammation. It's transient. It's acute. It's inflammation of the gastric mucosa, that inner layer of the stomach, okay, or the gastric mucosa is all along the GI system, but in this case we're talking about the stomach. So a severe nagging pain that does not last long and comes in short bursts. So probably all of us have had some experience with gastritis. Associated with local irritants, so aspirin is known to cause this. It's the acetylsalicylic acid is what aspirin pretty much is. And that can cause irritation of the stomach directly. NSAIDs can cause irritation through various ways. Oral steroids can do it, these are the most common. So drugs a lot of times can cause stomach upset. They talk about stomach upset. But also bacterial endotoxins, so bacteria, and if you're thinking like H. pylori, you're right, so that can cause acute gastritis or gastritis. Caffeine foods, caffeine, spicy food, alcohol, it affects people. Different people react differently to these things. Bacterial endotoxins is pretty universal, but you know, different people react differently to different foods, things that are put in there, and medications, and so that's what gastritis is. And remember, as I mentioned, that really only involves the stomach because we're talking about gastritis. So chronic chronic gastritis, it's an inflammation, but it's characterized by the absence of really visible erosion. So we can kind of see in this picture down here that there's inflammation that's taking place, but it's not really causing an ulcer or something. There isn't any ulceration or lesions that are taking place. So presence of chronic inflammatory changes, atrophy of the glandular epithelium of the stomach, so the glandular area that's releasing stuff, so that can atrophy, and it could be immune, could be non-immune, but whatever, either way, we're talking about something that is chronic. Okay? So there are a few different types that may or may not make sense. Helicobacter pylori, so this is what is infamous for causing ulcers, but it can cause this gastritis as well, and then may progress to cause ulcers. Chronic autoimmune gastritis, so whatever your immune system has launched a defense against this mucosal or glandular mucosal layer of the stomach. And then chemical could be, well, just that. Any kind of chemicals, even something chemicals from like aspirin, could cause some of this inflammation. So chronic, 10% of all associated with other autoimmune diseases like diabetes, Addisons seem to kind of run in the same circles. If you have one autoimmune disease, there's a reasonable chance you can get others, or an increased chance, I should say. Autoantibodies to parietal cells. So remember, parietal cells are what are making the hydrochloric acid, and they're also making intrinsic factor. Okay, so that means that for whatever reason, your immune system has targeted parietal cells, specifically in this case. So autoimmune affects the body and the fundus, just different regions of the stomach, slow and progressive, and can lead to this gastric stomach atrophy, so shrinking, especially, I mean, the immune system is physically trying to destroy the stomach or parts of the stomach. Manifestations may be the same as B12 anemia. I have the question why behind that, and that's because the parietal cells, if they're damaged, can lead to the loss of intrinsic factor, and you need intrinsic factor to take up and absorb B12. Okay, so that's why that's the case. So chemical gastropathy. I didn't think about this before. So chronic reflux of pancreatic and bile secretion. So remember, the pancreas and the bile are making enzymes. So they're making enzymes, but they're supposed to be putting those in the small intestine. So if we have reflux from the small intestine, remember that pyloric valve. So if we have reflux of these chemicals, these enzymes that move back up into the stomach, then that can cause some irritation, some inflammation in the stomach as well. So chemical gastropathy is seen from chronic reflux of pancreatic and bile secretions into the stomach. Associated with gastroduodenostomy, gastrojejunostomy, which is pretty much very basic explanation, pretty much where they take the duodenum and they may attach it directly to a different area of the stomach to allow drainage to take place, and then you're going to have a more accessible way for some of these the pancreatic juices, that's what they're called, to move to reflux back up, and bile secretions to reflux back up into the stomach. So let's talk about H. pylori, Helicobacter pylori. It causes damage to the stomach lining. It's almost like it's kind of hell-bent on doing that. It has enzymes, so this bacteria has enzymes, produces enzymes that break down the mucin. So mucin is the little protein that gives mucus this kind of thick, slippery consistency. And so H. pylori can actually damage that mucin, and then, which is going to interfere with the protection, because that's what the mucus is for. The mucus is to protect the mucosal lining, the inner lining of your gut all the way through. And so H. pylori can kind of get a foothold in there, damage that mucin, which is going to compromise that protection against acid. So they also produce toxins that directly damage the mucosa, and they can produce ulceration. So initially they can produce gastritis, okay? But then they can also lead to ulceration. So H. pylori in general is the major cause of peptic ulcers, and the second most common cause of ulcers. So we talked about how NSAIDs can cause gastritis. NSAIDs can also cause ulcers, but mainly ulcers are caused by H. pylori. So treatment, antibiotics. Well, it's a bacteria. So fortunately, it's a bacteria that antibiotics can, for now, kill. So that can kill the bacteria, and then you can use proton pump inhibitors to reduce the acidity. So reducing the acidity is also kind of a good thing to do as well during treatment. All right, I know that wasn't a very good way to say that, but whatever. So peptic ulcer disease. Now we're talking about when an ulcer has formed. So it's called peptic ulcer. It's not specific to the stomach. So it occurs in areas of the upper GI tract. So it can happen in the stomach and it can happen in the duodenum. Any of these areas that are exposed to acid, and really I'm talking about stomach acid. So as the stomach releases its chyme, which is food mixed with stomach acid, as it releases that to the duodenum, well, your pancreas is going to try to secrete something to neutralize that acid as soon as it can, but that still means that the first part of the duodenum is going to have exposure to the acidic contents of your stomach. Okay, so it's going to have exposure to this acid. So that means if the H. pylori moves in there, or something else causes damage to that mucin protection, that mucus protection, then you can develop an ulcer in that area. So characterized by spontaneous remissions and exacerbations. Some people have, flare-ups, their ulcers are flaring up or something like that. Causes H. pylori, mostly NSAIDs, aspirin, we also mentioned that. Signs and symptoms, pain. Okay, so pain, burning, gnawing, cramp-like pain when the stomach is empty. So when the stomach is empty and that acid isn't being diluted by anything, then the acid is going to get in there and kind of dig around and cause pain. So it's located near the midline, near the xiphoid area, and it's relieved by food or antacids. So either sort of diluting the acid that's already there, or giving an antacid which will directly kind of help neutralize it. So major complications, bleeding. Okay, so we're talking about a hole that is forming, or a lesion that's forming here. And so GI bleed, obstruction could occur, perforation. That ulcer could move all the way through, and then you would have the leaking of stomach contents out into other parts of that cavity around there. So duodenal ulcers are the most common of the peptic ulcers, and again, H. pylori. Hypersecretion of stomach acid can cause that. And remember, the first part of the duodenum is going to be affected by stomach acid. Use of NSAIDs is another one, so we already mentioned that. Characterized by intermittent pain in the epigastric gastric area, relieved rapidly by ingestion of food or antacid. So that can be kind of a diagnostic clue. So if somebody is having pain, but then when they take an antacid, it goes away, or when they eat, it goes away. If you think about it, that's kind of different from GERD, or acid reflux. So acid reflux, a lot of times ingestion of food causes it because it increases that pressure, and then the acids move back up into the esophagus. It's also going to be, kind of maybe higher up, but in this case, eating food relieves the pain. Okay, so that's kind of a different there, probably something to think about. So management is aimed at relieving the causes and effects of hyperacidity and preventing complications. Okay. Stress ulcers. Okay, so this is not mental stress. This is not, you know, when, like my dad, when I was little, used to tell me I was giving him ulcers. Okay, he was joking, but I think back in at that time, people thought that stress, mental stress, caused ulcers. It does not, or at least there's no real evidence that it does, especially after they found the H. pylori was mostly responsible for this, and you could treat it with antibiotics. So I wish we'd known that back then. I would have told him, no, Dad, it's H. pylori that's causing your ulcers. But there is something called stress ulcers, but it's not psychological stress or mental stress. This is physiologic stress. This means that something is not allowing nutrients, or it's not allowing your body to kind of take care of a certain area of your anywhere that's got this acid, your stomach or the duodenum. So it can be related to severe burns, illness, neural injury, systemic trauma, something like that that's causing a physiologic stressor. So basically severe illness, major trauma can cause it. Reduced plasma volume may occur, and that can lead to ischemia, necrosis. That's going to really stress the area. If it can't get nutrients into that area, then there can be necrosis, and that can cause an ulcer. That can cause ulceration in those areas. So intensive care unit patients are at particular risk, so they are routinely treated with proton pump inhibitors, H2 receptor antagonists. ICU patients have been stressed. I mean, surgery or some kind of trauma is going to be stressful in general, and so they may be given proton pump inhibitors, so to reduce that acidity, so the acidity won't get in there and kind of damage it even more. So there is something called a curling ulcer. Curling ulcers typically are associated with burns. Cushing ulcers are ulcers that develop as a result of brain trauma, which means that the autonomic nervous system may increase a release of gastric acid. So that could be activation of the parasympathetic nervous system, could cause that to take place. Now we're going to talk about malabsorption syndromes and then kind of move into the colitises. So malabsorption syndrome is kind of what it sounds like. Malabsorption, that means you're not absorbing things the way that you're supposed to be absorbing things. I mean, the whole purpose of the GI system is that you can eat, you can get nutrients, and then you absorb those into your body. So something is preventing the absorption of these nutrients. So a couple of examples that are relevant and that you'll hear about probably even after now, at least, is lactase deficiency. So lactase is an enzyme that breaks down the disaccharide lactose, which is a sugar found in milk, and it tends to break this down. I think it's glucose and galactose are the two monosaccharides, but it's supposed to break that down into individual monosaccharides, and then those can be absorbed. The monosaccharides can be absorbed. So what happens if you don't have enough lactase? So babies make lactase because they live on milk. That's what they have. But for most people in the world, after those baby years, they stop producing the lactase, and because in most parts of the world, milk is no longer introduced. Now there are certain areas where some areas in Asia and in Northern Europe where cow's milk was substituted as a nutrient for, like, hard times, winter, stuff like that. And so those people don't tend to have the lactase deficiency as much. But in most parts of the world, yeah, lactase deficiency can happen. And for most of those people, they're lactose sensitive. So for a lot of people who maybe can't have milk, can't have dairy products, they can retrain their body to do it. That gene is still there. That gene still works, presumably, because it worked at one time. And so sort of introducing milk can kind of increase or decrease that sensitivity and increase the lactase production. Now there are some people who are simply lactose intolerant. They cannot. They will not produce this lactase. and so they can't have dairy products at all. That's a smaller number. Like I said, most people are lactose sensitive, but lactose intolerance is just kind of a no-go all the way along. There's also something bile salts. So bile salts are emulsifiers. So normally, fat in the stomach, we usually have a fatty meal, and fat will tend to form these big globules. Well, we make bile salts, and these bile salts will kind of pick apart that big blob and turn it into a bunch of little droplets. Okay, we call that process emulsification. But that's what bile salts are for, is they kind of surround it and they break off that big glob of fat, and they turn it into these little droplets, and then those little droplets, your enzymes can move in there, and the enzymes can then break down that fat. The lactases can break down that fat. Okay, so if the liver is failing, then, or if the liver, for whatever reason, is not producing these bile salts, or maybe the gallbladder isn't working, or maybe there's a clog somewhere where the bile isn't being released, then you're not going to be able to break down fat, which means you're not going to be able to absorb fat through the intestine. Okay, so that's a malabsorption. You're not being able to absorb it, malabsorption syndrome. Now, one of the things that's sort of required for your fat-soluble vitamins, the A, D, E, and K, is that those tend to be more soluble in lipids and less soluble in water. And so they kind of get taken up with fats. So if you're missing bile salts, if you're not able to absorb fats in general, or if you don't have fats in your diet, that's another thing, is you really can't absorb these unless you eat them with fat, then these fat-soluble vitamins may not be taken up. So you can have a vitamin deficiency even though you're taking supplemental ADEK, you may have a vitamin deficiency if you don't have some presence of fat in your intestine that is being absorbed along with it, because it gets absorbed with that fat. So depending on the deficiency, the symptoms may include diarrhea, flatulence, bloating, abdominal cramps, weight loss. It really depends on what it is, and a lot of times it depends on the person. Some people respond differently. Okay, so now we're going to talk about inflammation. We're going to talk about the inflammatory bowel diseases. So specifically, the inflammatory bowel diseases are Crohn's disease and ulcerative colitis. So these are the IBD. So remember that, those two things, 1, 2. Then we're going to talk about infectious enterocolitis. Entero generally refers to the small intestine. And that's going to have to do with viruses and bacteria. And then we'll talk about diverticula, and then we'll mention IBS as well. So let's talk about inflammatory bowel disease. I really want you to get that categorization of these, because the two inflammatory bowel diseases are going to be Crohn's disease and ulcerative colitis. So really it's just a matter of sort of figuring out the key things that make these different. So Crohn's disease, recurrent granulomatous inflammatory response that affects any area of the GI tract. Now that's an important point right there. Affects any area of the GI tract, because ulcerative colitis is going to, well, it's in the name, colitis. It's going to affect the colon. So the Crohn's disease, that's the one we're talking about now, can also be the small intestine. So it can be the colon or it can be the small intestine. That's important for some of these things like malabsorption, which we'll get to. So the cause is unknown, may be immune related. And anytime you've got something that's cause unknown, people get it, and there are symptoms associated with it, then there are a lot of crazy ideas about what may be causing it. One of those crazy ideas may be right, I don't know, but you'll hear a lot of things that, oh, that's the cause of Crohn's disease. So kind of take that with a grain of salt, like, I guess, whatever you want. So onset of age tends to be 20s to 30s. Intestinal mucosa has a cobblestone. So cobblestones are, the cobblestone's appearance, where it's supposed to be kind of more nicely linear. Secondary to the presence of linear ulcerations. So linear ulcerations could take place. So that's going to be bleeding, edema, Inflammation may take place, especially since it is an inflammatory bowel disease. And if you have ulcerations and you have edema, then you're going to probably expect some bloody diarrhea, and that's definitely the case. Okay. So it's characterized by skip lesions, and we'll see on the next slide what we mean by skip lesions. But skip lesions is really, it means that it may happen in one area. Okay, so if you have your bowel there, so you may have lesions that occur in this area, you may have it occur in this area, this area. Okay, so that's what we mean by skip lesions. It's not just continuous, it kind of skips around. So sharply demarcated, you can see where it is. Granulomatous lesion surrounded by normal appearing mucosal tissue, which these lesions, so we're talking about lesions that, the affected area, non-affected area, and that's going to lead to pain. So malabsorption syndromes can happen. So remember, this is related back to it possibly having an effect. It can have an effect on the large intestine, but it can possibly affect the small intestine, which ulcerative colitis really doesn't. So malabsorption is kind of something that makes sense. I mean, if you're damaging the small intestine, most of the absorption of nutrients and water happens in the small intestine, then it makes sense that Crohn's disease can cause a malabsorption syndrome. Okay? So including B12, folic acid, these things may not be as easily absorbed. So manifestations: bloody diarrhea, colicky pains, that means quick and intense, in the lower right quadrant, weight loss, fluid and electrolyte disorders, malaise, low-grade fever, so that means that's kind of an indication of a systemic response, slowly progressive, and can be debilitating, so it just kind of keeps moving on through. All right, so that was Crohn's disease. Now let's talk about ulcerative colitis. Begins in the rectum and spreads proximally. Now that's very different than what we heard about with Crohn's disease, which had skip lesions. So ulcerative colitis begins in the rectum, which is the end of the colon, and then spreads proximally. So that means it'll spread to the descending and then maybe even as far as the transverse. So confluent and continuous lesions, not skip. And that's where it happens. It happens in these areas called the crypts of Lieberkühn in the submucosal layer. And so these are these little crypts, and that tends to be where the inflammation begins, and then it can spread. So symptoms: diarrhea, which can last for weeks, sounds awful, 10 to 20 a day, blood and mucus in the stool. So really what happens is, with a lot of these GI disorders, you're just having a hard time handling the food that's moving through here. Okay, so blood and mucus in the stool. Treatment: medications. So you can give medications. Immunosuppressive agents. It tends to be like Crohn's disease. There could be probably an autoimmune component to it. Surgery can take place. A lot of times they'll just remove, if this has gotten really bad, they'll just remove parts of the colon. And that's another reason maybe to remove parts of the colon, is because there's an increase in colon cancer risk. Okay, so we know that can happen. Okay, so infectious enterocolitis. So entero tends to be more associated with the small intestine. So microbial agents, viruses, it's infectious. Viruses, bacteria, protozoa infect the GI tract, causing a broad range of symptoms. Diarrhea, broad range, it's always diarrhea. Abdominal pain is another one that's often there. Perianal discomfort, ulceration can happen, and when you see ulceration, a lot of times that means that you could see kind of maybe some blood in the diarrhea. Hemorrhage is the bleeding. Okay, so intestines attempt to get rid of the infectious agent. So when we talk about infectious enterocolitis, there are a number of things that cause it. So there's rotavirus, C. diff, Clostridium difficile, and E. coli. E. coli could come from, food poisoning, that kind of thing. So that's what we're talking about. We're talking about enterocolitis. We're talking about, in some cases, just severe stomachache with diarrhea. So exudate to dilute toxins. So exudate to dilute toxins is kind of a fancy way of saying that you're starting to produce and dump water into the intestine. Okay? So you're dumping water in there, which is going to dilute those toxins, but it's also going to really increase that volume, and you're going to have some large volume diarrhea that's going to take place in that case. In the case that this is the way your body is handling. So hypermotility, vomiting, you're trying to push it out this side, your intestines are feeling very threatened. They feel like they either need to push it out one end or they need to push it out the other. So you can have, in addition to diarrhea, you can have vomiting. Decreased intestinal function, lack of absorption, so food's not absorbed. Osmosis draws more water into the bowel. Osmotic or explosive diarrhea may take place. And so let's look at some of the culprits. C. diff is a big one. So it's a type of bacteria that's normally a friendly bacteria. It's, well, I don't know that it's friendly. I shouldn't say that. But normally it doesn't cause any problems because there are so many other bacteria around it. So if you have your intestine here and it's dotted all along the way, and you have a bunch of friendly bacteria that are in there, and you just have a few of the C. diff, then what happens, and this is the thing to remember, is that if you take antibiotics, so certain antibiotics will kill off antibiotics kill bacteria. They're going to kill your good bacteria. They're going to kill your good gut microbes in addition to whatever else you're trying to kill. Okay, so whatever you're taking antibiotics for, hopefully it works for that. But the trouble is, one of the other problems is that it's also killing off your friendly bacteria. And if it kills off enough of the friendly bacteria and leaves behind the C. diff bacteria, then the C. diff will start to proliferate. Okay, so suddenly it's not competing as much anymore, and it can really take off. Okay, so the way we say that is we're going to say that the primary cause is antibiotic therapy. So the use of antibiotics, and so we're going to call it opportunistic. So it's not just taking over because it's such an aggressive bacteria. It sort of looks around and says, oh, gee, everybody left. I guess I'm going to start growing now. So opportunistic, usually intestinal flora are present that prevent the proliferation of it, but in this case, it can take over. So toxins lead to hemorrhage, inflammation, necrosis. It can be nasty, or people can get over it, but it's going to be associated with diarrhea and cramping 1 to 2 weeks after, usually following antibiotic therapy. So that's, again, one of the main things to keep in mind here. So there is a severe form, pseudomembranous colitis, which can be life-threatening. Rotavirus. Rotavirus is another one of these things. Remember, we're still in the category of infectious enterocolitis. So rotavirus, fevers, vomiting, last about 2 days, but diarrhea persists for 5 to 7 days. So this is something that's common in small children. My son had it. And it's just as advertised. Fever, vomiting, diarrhea. It's one of these disorders that, well, I guess it would be a disease that your body, the child's body, is trying to get rid of it. It's trying to push it out either through vomiting or diarrhea. The problem is that the virus sheds for several days even after resolution of symptoms, which kind of makes sense, I guess, if it's in the if it finds itself in the bowels, then it can be released. And the real problem of that is that, you know, people send their kids back to school, they take them to the pool, swimming pool, whatever, and then these viruses can be transmitted. Okay, so so for several days, even after resolution of symptoms, so symptom-free a lot of times doesn't mean you're no longer contagious. That's, you know, a general rule that people like to live by, but it really depends on the organism. So short incubation, 24 hours, and of course when you've got vomiting and diarrhea, especially when you have them both together, there's a risk for dehydration, especially in small children. Okay, so they're a little more susceptible to that. So something else called irritable bowel syndrome. So don't get this confused with inflammatory bowel disease, this is irritable bowel syndrome. So it's a symptom-based disease characterized, so symptoms which are going to be abdominal pain, so manifestations, abdominal pain, discomfort, pain, bloating, could be diarrhea involved, and but it's going to be pain. Okay. Recurrent abdominal pain with altered bowel habits. So we're not really committing to any kind of diarrhea, constipation, that kind of thing, but altered bowel habits. It's going to depend on, so different people would express that differently. So it tends to be more common in females, tends to be associated with anxiety, depression, reduced quality, or wait, okay, it's more common in females, and I don't even know that I need to say this, but someone with irritable bowel syndrome is going to have more anxiety, more depression, more reduced quality of life. That tends to be kind of, that's not something people want for themselves. They can be kind of intrusive in your life, and that's usually when a diagnosis is made. A lot of times quality of life effects can determine whether or not a diagnosis is warranted. So they can causes unknown, but all of these things. Visceral hypersensitivity. So that means hypersensitivity of the GI system. It's moving too much, so that means abnormal permeability, motility, secretion. Secretion means putting things into the intestine. Motility means moving them along. Can be found to be post-inflammatory. So you may have inflammation, then it may continue with the irritable bowel syndrome. Alteration in gut microbiota. That's one of the gut microbes that exist in there can be very specific, and so maybe it's changed. There's something different that may have something to do with that. In fact, I would give some credence to this. That makes sense with all the stuff we're learning about the gut microbes. It kind of could make sense that might turn out to be something relevant. Food allergies. So a lot of times that makes sense as well. I mean, a lot of times people may have a food allergy but have never identified it, and it gets in there, and it could be a specific protein, specific part of a specific food, and somebody may be intolerant to it. Psychosocial factors could have an effect, but anyway, manifestations, I already read this. So lower abdominal pain, discomfort, and bloating. Symptoms are bloating. Symptoms are usually relieved with defecation and do not interfere with sleep. So these two things are some questions that would be asked. So you have this problem. Does defecation, does that usually help? If so, then it can kind of push you in the direction of irritable bowel syndrome as a diagnosis. Does it interfere with sleep? Well, no, not really. Then that too. So no cure, and treatment is going to be individualized. One more thing that's going to lead into something else, diverticular disease. So diverticula are little outpouchings, so protrusions through the weakened layer of the intestinal wall. So remember those layers of the intestinal wall that we see, the mucosal layer, the muscularis layer, the serosa, those layers. What happens is with diverticular disease is that you get food in here and your intestine tries to be really, really strong, and if it has a hard time pushing it through, it's just going to squeeze harder, and a lot of times that can cause such increased pressure that it can push out, especially if it's weakened. This tends to happen a lot of times with older people, especially if parts of this intestinal wall are weakened. It will push out. It forms these diverticula. Okay, so these are just protrusions through weakened layers of the intestinal wall. It's associated with low fiber because remember, fiber adds bulk, and when you have bulk, then your intestines know what to do with that. So that's kind of a needed thing, is to have something that it can push on and move along. So even though you don't absorb, and this is an important thing, even though you don't absorb fiber, it can really be important for this formation of diverticula. If you have diverticula that form, they could perforate, which causes damage okay, which can lead to other kinds of irritations, which can lead to cancer. So a lot of times we hear, you know, you need more fiber in your diet because higher fiber diets prevent colon cancer. Well, they prevent colon cancer because fiber is going to make it easier for your colon to push things through. And that's going to reduce any kind of diverticula as an example, but it's going to reduce some other kinds of damage that can take place. So yeah, diverticular disease associated with low fiber, decreased physical activity, poor bowel habits, that kind of thing. So there are a couple of aspects to this diverticular disease. So diverticulosis, which means that the mucosal layer herniates through the muscularis layer. So we can see the mucosal layer is this area in here, and it's pushing out through there. So it's pushing out, but it still has that serosal layer around it. So yeah, it's pushing out, causing a diverticula, but in this case, it's just pushing out. It's not really perforating. It's not inflamed at this point. It's just pushing out. Okay, so it's considered diverticulosis. It's asymptomatic. You may not even know you have it unless you are checked for it. But the next stage, the next step, I don't want to say that it works in stages, but the next step, if something isn't done about this, is that it can become inflamed. This is an area where bacteria could develop and kind of take over that area. And if it does become inflamed, then you've moved on and you have what's called diverticulitis, which is an inflammation. So it can become inflamed and then it can perforate, and then you have a perforation or a hole that's developed in the colon, usually is where we're talking about. So diverticulitis, inflammation and perforation of the diverticula. In that case, it's not asymptomatic, which is a double negative. It is symptomatic. So pain and tenderness with nausea, vomiting, slight fever, especially because we're talking about bacteria. So if it becomes systemic, elevated white blood cell count. Okay, will be associated with this too. So the goal is to prevent flares by, again, increasing bulk and diet. So increasing fiber, which that's going to increase the diameter and decrease the pressure. I know it might sound counterintuitive, but it's going to, your intestines won't have to push as hard, so that's what's going to decrease the pressure. And regular bowel movements. So don't hold it, is kind of what that means. So treat with antibiotics, clear liquids if it becomes infected, diverticulitis. So peritonitis, now we just mentioned that we had a perforation. You could have leaking of the bacteria, leaking of intestinal contents into this cavity that we call the peritoneal cavity. So the peritoneal cavity is holding all of these internal organs, and it's supposed to, well, those internal organs aren't supposed to leak into this cavity. So that's what, so peritonitis is usually when something does get in there to cause inflammation. So peritonitis, as a definition, inflammation of the peritoneal lining. And the reason it happens, peritoneum is capable of containing an infection by profound inflammatory response with secretion of lots of fibrous exudate. Okay, so it's going to notice that something is leaking in, and it's going to start to launch that inflammatory response. So it's caused by infection, mainly. Bacteria enter via break in one of the abdominal organs. It can also be caused by chemicals. Can be complications of other problems. Really, anything that causes peritonitis is I know that sounds like a bad definition, but mainly we're talking about infection can take place, but it could be, you know, from surgery, trauma, something like that. Anything that's going to result in some kind of inflammation that occurs in the peritoneal cavity. So acute peritonitis, that's going to be pain. Pain, point specific, wherever it happens. It's aggravated with movement as opposed to like respirations or something like that. It's aggravated with movement, and this is always the definition that we hear: a rigid board-like abdomen. Okay, so you're not, since it hurts, and what that comes from is it hurts with the movement, so you are not going to move it. You're not going to, yeah, so, sorry, my phone went off. So you're not going to move, and that's what's causing the board-like and the guarding. Okay, celiac disease. So celiac disease is the last kind of disease we'll talk about before we barely mention neoplasms. So celiac disease, one of the most common genetic diseases. Know this one because this is, you know, the whole gluten-free wave that happened, but celiac disease is the original. Celiac disease is a genetic disease where T cells will actually attack your T cells. Your immune cells will actually attack gluten. Okay, so it's a T cell immune mediated response against gluten, leads to intense inflammation. So when gluten is in your diet, suddenly you're having a T cell mediated response, and that's going to cause, well, it can cause damage. We've talked a lot about immune responses and how immune responses can leave scar tissue behind. So these people with celiac disease have to avoid wheat gluten in their diet. So wheat gluten is a component of wheat, and so they have to be very, very careful. Now there are people, I didn't mean to minimize it, and there are people that seem to be sensitive. Some are sensitive to gluten. There are some who aren't, but some people like to avoid it for other reasons. But we're talking about celiac disease. We're talking about the genetic disease that is an actual autoimmune or an immune response to wheat gluten. So it leads to loss of absorptive villi in the small intestine. So that's part of this inflammatory damage that can take place. Seen in people, and this is true in a lot of cases, seen in people with other autoimmune diseases. So a lot of autoimmune diseases, people will have several of them. It's probably something genetic about their HLA. But and also hypothyroid, for whatever reason, tends to also be associated with it. I need to probably look into that, but I'm not sure why it is. So associated with higher risk for various malignancies, may relate back to the damage that's taking place. So manifestations may, or how it's expressed, may vary with age. Okay, so that was celiac. Now, all we're going to talk about, we could go on for, you know, another hour about colorectal cancers. Really, I'm just going to point out a couple of things and maybe some terms. So adenomas tend to be adenomatous polyps. So a lot of times we'll hear about polyps developing. Polyps are growths that can occur in the colorectal area, so the colon and the rectum. So these tend to be benign. Tubular villus, tubulovillus. Those are some of the I guess manifestations of the way that they're expressed. But this is these benign tumors. But they don't always, you know, they're not necessarily going to become malignant, but they are associated with malignancy, and then malignancy would be adenocarcinoma, which are malignant, cancerous, and this is why it's important to have early screening, because we can sort of notice these things. We can look for, I mean, even the diverticula, and we can say, okay, you know, this is how you need to alter your diet. This is how you need to alter, you know, your lifestyle in general. Okay, and that is it for the part one.